Yeah, thank you very much, ma'am, for the kind introduction. And it's really heartening to be included in the program organized by the Indian Society for Sleep Research and the NIMHANS. So today morning, since we have the mixed group, as I got the information from the mail, so we will try to look at the case discussions of different kind of circadian sleep disorders. I have tried to keep the talk as basic as possible and to be as clinically useful as I could make it. So the first case is a 24-year-old male who presented with difficulty falling asleep for past 6 months. He mentioned that the problem started gradually, but progressed over 1 month, and since then it is running the continuous course. He is having the problem He's having problem almost all nights a week, and he finds it extremely difficult to wake up in the morning. When he goes to office, he feels sleepy. He has lost interest in the day-to-day activities which were earlier pleasurable to him. Often he feels sad and distressed because of the symptoms. During the day, he feels some heaviness in the head and also suffers from the loss of appetite. He says that now he is not able to pay attention to the work that he is doing, and he makes errors. And the errors are not only related to the office work, but also because of the sleepiness during the daytime. uh, he at times just misses the accidents, and he says that he is having the 5 days working week. So he says the weekends are better. There is no history of substance use or any other medical disorder. He is already on the tablet sertraline 200 milligram and tablet clonazepam 1 milligram per day for 4 months, but there is no improvement. There is a family history of depression in mother, and she had responded only partially to the multiple antidepressants. Even after the treatment with antidepressants, uh, she had the residual symptom, and one of the major symptom which could not go with the antidepressant treatment was insomnia. His vitals are within normal limits. General physical examination doesn't add anything to the diagnosis, and the body mass index is 23.3 kilogram per meter square. He also brings the lab reports, CBC, LFT, KFT, thyroid profile, serum iron studies, which are within normal limit. Now, such cases are often mistaken for either insomnia or depression. And we have already seen that he's already on sertraline 200 milligrams and he is not improving. And this could be called a case of treatment resistant depression, because there is also family history of depression in the mother, which did not improve despite multiple antidepressants. So the key points are, in this case, you are not finding any response to the antidepressants. The person is suffering from excessive daytime sleepiness, perhaps because of the clonazepam. He find it difficult to fall asleep. There are multiple reasons to consider that why he's having difficulty. The common reasons could be the presence of anxiety, the sleep hygiene, the sleep environment, the presence of another sleep disorders like restless leg syndrome or insomnia, or maybe delayed sleep wake phase disorder. Now, he says that weekends are better. So, the issue is there cannot be any kind of depression which improves on the weekends and which presents only on the work days. So, considering all these issues, we have to review the diagnosis. Can it be a case of insomnia? Unlikely. because most of the patients with insomnia, they do not feel sleepy even during the day. At least they are not able to take the planned naps. Yes, unintentional naps can be there, but the daytime sleepiness could have been because of the clonazepam, which was given in high doses, that is 1 milligram. So we asked for the sleep wake schedule for past 6 months. So on the weekdays, he goes to bed at 10 p.m. It takes 3 to 4 hours to wake up. He does not have any nocturnal awakening. He wakes by the 6 because by 8:30 he has to reach the office. After waking up 6 o'clock in the morning, he takes around 40 minutes to leave the bed. So the wake after sleep offset is around 40 minutes. Daytime sleepiness is remarkable. The mood is low, headache and appetite is present on the weekdays. But what happens on the weekend? He goes to bed at 1 o'clock and falls asleep within half an hour, wakes up by 10 o'clock, and he feels fresh. So it takes not more than 10 minutes to leave the bed. He does not feel sleepy during the day on the weekends. So that again shows that the sleepiness is not because of the clonazepam. His mood is better on the weekends, which suggests that it is unlikely to be a case of depression. He does not feel headache on the weekend, and appetite is also better on the weekend. So what we do, we give him a sleep diary. Now, before looking at the sleep diary data, first we need to consider the difference between the delayed sleep wake phase disorder and insomnia. So on the topmost panel, you can see this uh, the person who is having the normal sleep wake schedule. So a normal person goes to bed at 10, wakes up by 6, spent around 8 hours in the sleep, and during the day he does not have any trouble and he is able to function well. On the other hand, the people with the insomnia, they have difficulty either in falling asleep or staying asleep, or they wake up earlier than the desired wake time. During the day, they are not able to fall asleep, especially the planned naps. Yes, unintentional naps can be there. And during the daytime, they feel tired, fatigued, and they are not able to function well. Thirdly, come to the case that we are discussing. So, such cases when they are allowed to follow their own sleep wake schedule, so they go to bed at 1 o'clock, wake up by 9 or 10 a.m. in the morning. So, they spend around 8 to 9 hours in the sleep every day, like a normal person. And they, if they're allowed to follow their own sleep wake schedule, then they do not have any kind of trouble during the day and they are able to function well like a person without any sleep disorder. So if they are able to function well, then why do we call it a sleep disorder? We call it as a disorder because their sleep wake cycle actually does not match with with the environmental timing and the social responsibilities. So when these people, they have to function and they have to manage their sleep wake schedule according to the environmental timing, they feel symptoms during the day which are mainly the sleepiness that we see in the patients who are sleep deprived, and they are not able to function well, similar to the patients of insomnia or hypersomnia. So this is the reason that delayed sleep wake phase is known as a disorder. Now, what to do next? To confirm the diagnosis, we can go either for the actigraphy and or the sleep diary. It is often better to combine the both. If you have the actigraphy, then actigraphy should be used along with the sleep diary. So this is the sleep diary that we get from this patient. So and we ask him to follow his own sleep wake schedule as far as possible. So now here you are seeing that he goes to bed between 1 to 3 a.m. every day. He wakes up at around 10 o'clock, but on the days when he wakes up earlier, He takes nap, so he feels sleepy during the day. On the other hand, when he wakes up according to his own schedule, on those days he does not feel sleepy and doesn't take naps. So this clearly shows that this is basically the delayed sleep wake phase disorder. So this is how we diagnose this disorder. Now, who is at risk for delayed sleep wake phase disorder? Adolescents and young adults, they are at risk. And among the adolescent and young adults, the prevalence varies between 7% to 16%. Of course, this is a US data, and we don't have any data for the Indian population. Around 10% of the patients who are suffering from delayed sleep wake phase disorder, they often complain of insomnia. It is more common in the patients who are having evening chronotype. So if the chronotype can be measured using the morningness, eveningness scale, which is available freely over the Google. Uh, the delayed sleep wake phase disorder has been found to be associated with polymorphism in the PER3 gene in the human. Nearly 40% of the patients, they have positive family history, and these patients often they report that they had delayed light exposure in the morning and excessive light exposure in the evening, which also contributes to the phase shift along with the genetic predisposition. And many of these patients, especially on the working days, they consume excessive amounts of stimulants to keep themselves awake and alert. And that also actually contributes to delayed falling asleep in the night. And that further perpetuates the delayed sleep wake phase disorder. Coming to the another case, a 74-year-old male presented with difficulty in the sleep for almost 4 years. The family members complain that he wakes up too early around 3 o'clock. The symptoms appeared gradually, but they are running the continuous course. He has the problem almost every night in a week. He feels sleepy during the daytime when he attends the meeting along with his peers. It's not an official meeting. He feels fatigued early in the evening by 5 or 6 clocks. And he feels better if he takes a nap during the day, especially the late afternoon. He gives a history that he stayed in an ashram for 1 month, 6 months back, and there he did not have this trouble. There is no history of substance use or any other medical disorder. He has been on tablet lorazepam given at 10 o'clock in the night to improve his sleep, but there is only partial improvement. There is family history of either RLS or insomnia, which could not be clarified in the mother of the patient. She had the partial response to the benzodiazepines. And even after the treatment with benzos, she appeared depressed. So that's again a query. We are not sure whether it was depression or the fatigue. On examination, vitals are within normal limit. General physical examination does not add anything to the diagnosis. BMI is 25.3 kilogram meter square. He carries the laboratory investigations again, which are within normal limits. So the key points in this case is he is not having any response to the benzodiazepine. I'm sorry, this is a typo, antidepressants. He feels sleepy late in the evening. He wakes up early. So again, we have to look for the reasons why is he waking up early. This could be part of depression. This could be the part of circadian rhythm sleep disorder, especially the advanced sleep wake phase disorder. This could be the normal environmental issues that he might be having in and around the bedroom. He feels fatigued in the early evening, and the naps they improve the symptoms, so that suggests that he is sleep deprived. So, in say having all this background, we need to review the diagnosis. So, since he is not improving with the benzos, so it is unlikely to be a case of insomnia. So we asked for the usual bedtime and the wake time, and remember he had the resolution of symptoms in the ashram. So we asked him the history, history of the sleep wake schedule that he follows usually, and at the ashram. So normally he says that the family they take the dinner at around 9:30. So he has to delay his sleep by 10 o'clock. But as soon as he goes to bed, he immediately falls asleep and he does not have any awakening. He wakes up by 2 o'clock in the night and say he feels little sleepy, so he takes around 2 hours to leave the bed. During the day, he is feeling daytime sleepiness. But when he went to the ashram, he used to go to bed at around 8 o'clock. He used to fall asleep within 15 minutes and he used to wake up by 2 o'clock. And it took 10 minutes to him to leave the bed. And there he discontinued lorazepam as well. And he did not feel the daytime sleepiness in the ashram. So it is possible that the sleep inertia that he's experiencing at 2 o'clock could be the result of the lorazepam that he is taking, because lorazepam is an intermediate acting benzodiazepine, and the sleep deprivation, because he's delaying his sleep by almost 2 hours every day, that can contribute to the daytime sleepiness. So it's basically a case of advanced sleep wake phase disorder. So what happens in advanced sleep wake phase disorder? Contrary to the normal and the insomnia people, these people they go to bed early in the evening, and they usually wake up early in the morning. So they have the normal total sleep wake time if they are allowed to follow their own sleep wake schedule. But when they are enforced to follow the societal timing, then they become sleep deprived, and which can be mistaken either for the terminal insomnia or the hypersomnia, because they feel sleepy early in the evening. So in this case, we have to again go with the actigraphy as well as the sleep diary. Now, the daytime sleepiness could be because of three reasons in this case. One is the sleep deprivation, as we have already discussed. Again, along with the aging, remember this patient ages 74 years. So as we age, there is some of the reports suggest that there is some advancement in the sleep wake schedule and the circadian rhythm. So these people, they feel they have actually broken sleep. So they take 4 to 5 hours of sleep at night, and also they have another sleep period that they feel late in the afternoon. And thirdly, this could be related to the benzodiazepine, as we have already discussed. So we give him a sleep diary and we ask him to follow the sleep wake schedule that is convenient to him. So when he comes with the sleep wake diary after 14 days, it shows that he goes to bed at around 6 in the evening. He falls asleep within 15 to 20 minutes, not more than that on most of the days. And he wakes up between 1 to 3 a.m. and then he does not feel sleepy if he is not taking any kind of medication. So here we can see that this is not a case of insomnia. Had it been a case of insomnia, we would have expected either delay in falling asleep, or a middle insomnia here somewhere, or terminal insomnia here somewhere. But here what we can see that the total sleep time is normal. It's around 7 to 8 hours per day, even at the age of 74. But there is just a shift in the sleep wake cycle. So this is basically a case of advanced sleep wake phase disorder. Now, the prevalence is not known. The advanced sleep phase disorder can have a prevalence of around 1% in the middle-aged population, that is 40 to 60 years. The prevalence increases with the advancing age. Certain neurodevelopmental disorders like autistic spectrum disorder, intellectual disability, these children and persons, they have the problem with the advanced sleep phase disorder. There is one major syndrome. This is Smith-Magenis syndrome, where there is an alteration in the melatonin secretion, and the melatonin secretion occurs mostly during the in the presence of the light. So the children with this Smith-Magenis syndrome, they have a reversal of sleep-wake schedule. Not only the children, even the infants, their parents complain that the child sleeps throughout the day and remains awake whole of the night. So whenever you are getting such children and the infants, always look for the Smith-Magenis syndrome. There are certain the advanced sleep phase disorder can also run in the families, and in the familial cases, the age of onset is usually earlier than the general population. Coming to the case 3, we have a 30-year-old male who presented the difficulty in falling asleep for 2 years. He feels sleepy at work for almost 2 years. He works in an airline office. He feels stressed at the job, and he always feels tired during the daytime. He says holidays are better. He's been prescribed hypnotics because he has difficulty in falling asleep for almost 2 years. So he's on clonazepam, zero point 0.5 milligram per day for 2 years. But it did lead to only minimal improvement. To remain awake and alert, he consumes 4 to 5 cups of coffee at the workplace. There is no history suggestive of substance use or any other medical disorder. There is similar to the previous case, there is history of either RLS or insomnia in the mother who responded only partially to the benzos. On examination, the vitals are within normal limit. General physical examination does not add anything to the diagnosis. BMI is 25.3, and also all the lab reports are also within normal limits. Now, if you look at the job profile, this person works at the front desk in the airline and he is having shift duties. And the shift moves from night to evening to morning. And he has to follow these shifts 5 days a week, followed by 2 offs. And we have also from the history that weekends are usually better. So what could be the possible diagnosis? It is actually shift worker disorder. So what is the key features with the shift worker disorder? The patients, they present usually with the complaints of insomnia, because when they want to go to the bed, so they are not able to fall asleep. And at the workplace, they feel sleepy. Now, this sleepiness can be present in all the working shift, whether it's night, evening, or the day. And whenever they, especially in the night, after the night shift, they have to sleep in the morning or in the afternoon, which is again contrary to the biological circadian rhythm that we have. So they try to fall asleep because of the homeostatic pressure uh, at a time which is not in sync with the circadian rhythm. So they are not having good quality sleep. These patients' total sleep time is often reduced, and their work schedule often overlaps with the usual sleep time. So usual sleep time is our the night time. So work schedule overlaps with the sleep time. Prevalence of shift worker disorder is around varies between 2 to 5% in general population and between 10 to 40% among shift workers. Again, this is basically data from the US. We don't have any data from India regarding the prevalence of shift worker disorder. Now, the people who are working in the shift and who are having high reactivity to the circadian shift and whose sleep reactivity is high, they are at risk for developing shift worker disorder, and that is the reason not everyone who is working in the shift they develop shift worker disorder. Coming to the fourth case, a 10-year-old male child has been brought to you. Is a known case of intellectual disability, which is moderately severe. The parents complain that the child wakes up again and again at night and he takes multiple naps during the day. The longest sleep period in one go does not last more than 3 hours. If we calculate the total sleep time in 24 hours, it's normal for his age. And the symptoms are present since he was 6 years old. That means for past 4 years. There is no family history. He remains in home most of the time and he is having minimal social interaction. So the key feature is if we consider the daytime naps that he might be considered as a case of hypersomnia, and if we focus on the nighttime symptoms, he can be considered as a case of insomnia. But always remember, insomnia and hypersomnia, they cannot be present in one patient together. So this also gives rise to the possibility that we are not dealing with a case of either insomnia and hypersomnia. The total sleep time is normal, uh, which is divided across multiple episodes of the sleep and the wakefulness. And there is day-to-day variability in the nap periods and the nap timing, as well as the sleep periods and the sleep timing. So this would be considered as irregular sleep-wake rhythm disorder. The children who are having the neurodevelopmental disorder like Angelman syndrome and autistic spectrum disorder, they are at risk for development of irregular sleep-wake rhythm disorder. Similarly, the patients who are suffering from neurodegenerative disorders like all forms of dementia, Parkinson's disease, they are also at risk for developing irregular sleep-wake rhythm disorder. Coming to the last case, we are having a 25-year-old male who is having poor visual acuity since 5 years. The family members complain of the hypersomnia during the daytime and multiple naps during the day. They also complain that he is having periods of insomnia, so he feels difficulty falling asleep, but there is no difficulty in staying asleep. But yes, on some of the days, he feels it extremely difficult to wake up at the usual wake time. There are certain days where he does not have any symptoms. So you ask him, you give him a sleep diary and the actigraphy, and that shows a progressive delay in the bed time and the wake time every day. So this is the sleep diary. You can see here the person does not have any trouble in waking up in the middle of the night. The sleep onset latency appears normal, but the sleep and the wake time it delays by almost half an hour every day. So at some periods of time, like here, like this period, his sleep wake schedule is in sync with the environmental timing. But on the other days, this could be mistaken for the periods of hypersomnia, and this could be mistaken for the periods of insomnia. So this is known as non-24-hour sleep-wake rhythm disorder. 50% of the blind persons they develop the non-24 hours sleep wake rhythm disorder because they have not only the loss of rods and the cones, but also they have loss of the ganglion cells, which are the basic photoreceptors and which carry the signals to the suprachiasmatic nucleus. Many of the patients who are suffering from delayed sleep wake phase disorder Once you start the chronotherapy to them, they can also fall prey to the non 24 hours sleep wake rhythm disorder. Children with neurodevelopmental disorders like Rett syndrome, autistic spectrum disorder, Angelman syndrome are again at risk for development of non 24 hours sleep wake rhythm disorder. And also the persons with traumatic brain injuries are at risk. So we have discussed five different circadian rhythm sleep disorders, namely the delayed sleep wake phase disorder, advanced sleep wake phase disorder, shift worker disorder, irregular sleep wake rhythm disorder, non 24-hour sleep wake rhythm disorder. So what is the core pathology in all these cases? The core pathology is the mismatch between the environmental timing and the body clock. So the suprachiasmatic nucleus does not get entrained with the environmental timing. And there could be multiple reasons for this. There could be the polymorphism in the multiple genes which regulate the circadian clock, and also the people who are having the other zebras which are important for the entrainment, like the light, social activity, exercise, physical activity, the rhythm of the food intake. When these are also not in sync, or these also vary, then the people who are at risk, they develop circadian rhythm sleep disorder. How do we diagnose? We can use either actigraphy or we can use the sleep diary. But the only problem with the sleep diary is that it becomes really cumbersome for some of the patients, and they don't feel comfortable filling the sleep and wake time every day. So you can also use the actigraphy for the diagnosis of CRSDs. But the problem is, this is the recent guideline for the use of actigraphy, and this says that only two studies are available, so the meta-analysis was not possible. The studies had the small sample size, so there is a scope for the imprecision. But the task force recommends that the actigraphy can be used to mark the sleep onset time and the sleep offset time correctly in these cases. So can be used in conjugation or solely or alone in the cases of for the diagnosis of the CRSD, and also for the during the management. When it comes to the management of circadian rhythm sleep disorders, the American Academy of Sleep Medicine, it recommends, it gives various guidelines, but the strength of evidence are weak for most of the guidelines. So, for the treatment of delayed sleep wake phase disorder, you can use strategically timed melatonin. That means we give the melatonin tablet around 1 hour before the usual time when we expect melatonin surge. So this can be used in the adults with or without major depressive disorder, children and adolescent with and without psychiatric disorder. And when the patient are given and you can also use the light therapy after waking up early in the morning along with the behavioral treatment. For the management of advanced sleep wake phase disorder, it is the task force recommended that we use the bright light therapy in the evening. But again, the strength of evidence is weak. For irregular sleep wake rhythm disorder, for the patients of dementia, we can use light therapy or a combination of light therapy along with the strategically timed melatonin. But they strongly suggest that hypnotics and melatonin alone should be avoided for the management of irregular sleep wake rhythm disorder. So even if you use the melatonin, should be in combination with the light therapy. For children and adolescents, you can use strategically timed melatonin. And for the non 24-hour sleep wake rhythm disorder, strategically timed melatonin may be used. How to treat the shift worker disorder? First of all, it is good to have the clockwise rotation of shifts. That means the shift should move from morning to evening to the night, with the at least 2 days gap between the when the shifts are being changed. Unfortunately, in Indian setting, I've seen so many cases and the factories which have the counterclockwise rotation of shifts. So this is something I think this what we can do. The person should have adequate sleep at the baseline. During when they want to fall asleep, environment can be manipulated. So the room may be kept dark. Room may be made non-noisy. The temperature can be made say convenient such that it is convenient for them to fall asleep. Uh, Exercise and caffeine and alcohol should be avoided as far as possible. Subjects can be advised to take the preventive naps, especially when they are going for the night shift, so they can take the nap late in the afternoon. Or when they are at work, they can take power naps to allay the fatigue. And the circadian phase shifting measures like light therapy and the strategically timed melatonin can also be used. Now, how to shift the transition from evening to night shift? So if a person is presently in the evening shift and preparing for the night shift, so evening shifts is say it is spans between the 5 p.m. and 1 a.m. So he should on day one, on night one, he should sleep at 3 o'clock to wake up at 11. On second night, he should go to bed at 5 and wake up at 1. On third night of the evening shift, he should go to bed at 7 and wake up at 3. On day 4, he should go to bed at 8 and to wake up at 4. And then he can go for the night shift, and then he can go to bed after coming from the night shift, and he can have the sleep from 9 a.m. to 5 p.m. So these are the recommendations from the American Academy of Sleep Medicine. So in summary, circadian rhythm sleep disorders are common in a specific population, more prevalent than the general population. Genetic factors as well as the environmental factors, they both play a role, and their interaction actually give rise to the circadian rhythm sleep disorder. CRSDs may masquerade symptoms of other sleep disorders and can be mistaken for a number of psychiatric disorders. Diagnosis at time is difficult, and regarding the management, we do not have much data, and the guidelines that we have, they are preliminary and only provide the weak evidence. Thank you very much for your patient listening. So I finished my talk here. Thank you very much.
Thank you, Ravi, for that wonderful talk. I think we will take up some questions now.
Anybody having question, please type into the chat box. Dr. V,
There is one question.
are you able to see the chat box, or should I read it for you?
No, I see the chat box.
Yeah.
Yes, I think the activities around us definitely they can influence the circadian rhythm, provided they create a trouble in your falling asleep or staying asleep. So once the external factors, definitely they can influence our circadian rhythm, provided we are sensitive. I mean, you have the sensitivity for the alteration in the circadian rhythm.
There is
Yes, newer generation watches, again, if we talk about the consumer technologies, as of now, we do not have any scientific data whether they can measure the circadian rhythm sleep disorder accurately. So as of now, it is not recommended. It is better to go with a medical grade device like Active Watch or any of the other actigraphy. Delayed sleep phase disorder, whether it does have any implication for the health, again, it is not sure. But in general, what is said that if you are not sleeping on time, that is, I mean, we are basically a diurnal species, so we are by nature we are designed to fall asleep late, early in the night and to wake up early in the morning. So there have been number of studies which suggest that the people who go to bed late in the night, even after having the normal duration of sleep, they may have increased chances for having obesity, increased chances for having the dysregulation of the metabolism, especially the glucose metabolism. So, but again, we do not have the robust scientific data which suggests whether the timing or the duration or the quality of sleep, which one is most important. So I think that's a open research question, and this should be done in future. Uh, People who sleep more than 9 to 10 hours without disturbance, quiet sleep, either they feel lots of weakness in the day. Why? It means more sleep is not good. Well, when we talk about the sleep hours, the more important is to find out whether such person is a long sleeper or his sleep time has extended because of some kind of sleep disorder or sleep disturbance. So if the person is a long sleeper, then after waking up after spending 9 2 hours in sleep, and when they wake up, they feel alert and awake. If they still feel fatigued, that means something is wrong with the sleep quality, and they should be screened for sleep disorders like PLMD. They should be screened for sleep apneas. They should be screened for sleep-related seizures and parasomnias. So, long sleep is actually, uh, in presence of fatigue, is not good. Is functional disorder in the brain seen due to sleep pattern? Yes, there have been number of studies which suggest that delayed sleep-wake cycle increases the risk for number of psychiatric disorders like addiction, depression, and anxiety. Many new mothers subscribe to the concept of leaving their child in the baby cot even if awake uh, before bedtime without helping them to sleep is the healthy way to develop sleep routine. Well, again, I am not really sure whether this is a good routine, but it's a common practice, especially in the West. So as of now, I don't have any data, and maybe any one of you who is having the data, you can share your response. Any authentic and free internet resource where we can go and find out whether one has any type of sleep disorder, not for the diagnostic purpose, for self-assessment. Uh, I think you can go to the website of American Academy of Sleep Medicine or European Sleep Society, or also the Indian Society for Sleep Research, as well as the World Sleep Society. So there you can find resources which can help you to find out whether the literature which can help you to say give an response to what you have asked.
There's one more question.
Yeah. Will active day increase the need for sleep? Uh, yes, in the normal person who are not having insomnia, actually having a I mean, having a structured day. I would not say busy, but I would rather say a structured day actually helps. There's again a Zeitgeber. It's a social Zeitgeber, and it actually helps you to entrain your suprachiasmatic nucleus to the environmental timing, and it helps you to fall asleep.
Thank you, Dr. Ravi.